So my charge is to talk about atrial fibrillation. I have a lot of disclosures. None of them really are relevant to this presentation. How big of a problem is atrial fibrillation? Well, we know that atrial fibrillation increases with age, and this is a recent publication that shows the increasing prevalence of atrial fibrillation as a function of sex and as a function of age. One of the interesting things is this is a new estimate, and the most recent estimate in terms of the number of patients with atrial fibrillation is actually 10 million in the United States alone, 4% of the population. This is 4 times higher than what we previously thought. This just got published in JACC. AFib worsens outcomes. We know that it can cause symptoms in patients, but most importantly, it increases the risk of stroke, mortality, heart failure, and dementia. Now, I'm going to focus really on stroke risk and prevention of stroke with oral anticoagulants, but we also have increasing data that eliminating atrial fibrillation, that is rhythm control, also improves outcomes. But let's talk about stroke. And one way to think about this is how good are we doing today? In the United States, if we look at the patients who are actually still presenting with AF-related stroke, and this is from the NEURO-AFib study, which is a study that includes a number of centers in the United States, including almost 7,700 patients who presented with AF-related stroke. And the question was, who are these patients? And here's what we see. 3/4 of the patients are patients who had known atrial fibrillation. And of those, 35% were patients who are so-called OAC failures, so patients who were on oral anticoagulants and still developing ischemic stroke, perhaps noncompliance, perhaps these are patients that need additional strategies like oral anticoagulation plus mechanical approaches. 41% are patients who weren't utilizing oral anticoagulants. So these are patients who presumably are thought to be at high risk for stroke or decided the patients didn't want to take the anticoagulant. And again, we need to more carefully try to get these patients on oral anticoagulant. But we also see 1/4 of the patients are patients who didn't have a previous diagnosis of AFib until they presented with this ischemic stroke. And this is where early diagnosis may have an important impact. And we're going to talk about a couple of things: implantable devices, implantable loop recorders, wearables, et cetera. So when we think about extending the benefits of stroke prevention to so-called early atrial fibrillation, we can look at it from the perspective of opportunistic identification. So patients who, for example, have pacemakers or defibrillators, because remember, these are patients who are older, who oftentimes also will develop atrial fibrillation. And we can look at it from the perspective of prospective screening, whether it's invasive with implantable loop recorders or non-invasive with all of the different types of devices that you're well aware of, watches and such. So let's start off with opportunistic identification. And what is the data? Well, the two, and this is so-called subclinical AFib or atrial high rate episodes. So these are episodes that are detected on pacemakers or defibrillators who were implanted for other reasons. There are 2 important trials, NOAA AFNet6 and Artesia, which were both published last year, and particularly Artesia, which is the larger of the 2. Both of them looked at patients who were elderly, who had risk factors. NOAA focused on patients who had AF episodes greater than 6 minutes, and Artesia greater than 6 minutes and less than 24 hours. Both of them randomized these patients between a non-warfarin oral anticoagulant, either edoxaban with NOAA or apixaban with Artesia, against either placebo or aspirin. And here's what was seen. You can see that compared to the control arm, whether it was placebo on the left or aspirin on the right, the oral anticoagulant group did better, and it reached statistical significance. Oh, it's interesting. This is off by 1 slide, isn't it? Okay, so you guys probably were confused what I was talking about. Okay, so if we look at this slide, you can see that whether it's placebo or apixaban, the oral anticoagulant group in both actually fared better. With Artesia, which was the larger of the 2 trials, it actually reached statistical significance. And this is a meta-analysis that was published for these 2 trials. For ischemic stroke, there was about a 30% reduction when you look at the combined endpoint. And there was a cost, which is an increase in bleeding of about 90% higher increase in bleeding, which is not a terrible surprise. And that probably is the reason why all-cause mortality was not statistically significantly different. But I think the important point is that you can prevent strokes in these patients, but perhaps not in all the patients. And so a lot of the work that's been focused is trying to identify which of these device-detected AFib patients are the ones that are the highest risk, the ones that are likely to benefit the most. And there are a couple of sub-studies that are worth looking at. This is an Artesia sub-study that asked the question, does the duration of AFib matter? Those episodes that were less than an hour, 1 to 6 hours, between 6 and 24 hours. And the answer, as it turns out, is not really. At least based on this study, there was no statistical significant difference. And in fact, the patients that had the longest episodes between 6 and 24 hours, actually the the dose response, so to speak, went in the opposite direction. Okay, so looking at the duration, at least in those episodes less than 24 hours, didn't seem to help. This is another publication. Actually, this hasn't been published yet. This is only presented. And I think this is one that's a little more perhaps useful, which is to look at outcomes based on the underlying patient risk, so the CHA2DS2-VASc score. And let's take a look. So they split the patients between those that were less than CHA2DS2-VASc, equal to 4, and greater than 4. And you can see it's approximately equally split. And if you look at strokes prevented, there was a difference. And in fact, perhaps not surprisingly, those patients that had the highest CHA2DS2-VASc score had the greatest benefit in terms of stroke risk reduction. Bleeding, not much of a difference. There's really no dose response, but the point is that this highest risk population are probably the patients that will benefit the most from oral anticoagulation. Let's move on to, let's say, prospective screening. And first, let's look at invasive detection. And there's one important trial, there's several, but the biggest one is the LOOP trial. And this is a prospective randomized trial looking at patients who are elderly. Really, they ended up with a CHA2DS2-VASc4 population approximately. And they randomized these patients between an implantable loop recorder strategy, meaning put the device in, if they have AFib, give them more anticoagulation, versus a pure control. It was powered for a 35% reduction in events. What was seen was, yes, when you put an ILR, shown in red, you detect AFib more frequently. Not a big surprise. And that causes the initiation of oral anticoagulation. Again, not a big surprise. But there was no significant difference in the primary endpoint of stroke or systemic embolization. Now, you get the impression that if you look at the curve in the red, the ILR group, that maybe there would have been statistically significant difference. Notice that the hazard ratio was 0.8, so it was a 20% reduction. So this was powered for a 35% reduction, perhaps a little too optimistic. And perhaps if you had, they had powered for 20% reduction and had 10,000 patients, you would have seen a statistically significant difference. But this is a negative trial at this point. There are some interesting sub-studies. If you look, for example, NT-proBNP, those patients had an elevated NT-proBNP, indicative of high left atrial pressure, perhaps left atrial size. You see a difference here. Again, this is a positive result from a negative trial, but it's certainly hypothesis generating. Another interesting thing in looking at ECG markers. And in this particular sub-study, what was very interesting is, particularly when you look at intra-atrial blocks, so conduction disease in the atrium, indicative again of fibrosis, perhaps dilated atria, et cetera, then you do see again an improvement with the ILR-based oral anticoagulation strategy. This is a publication a study that we did, Josh Lampert from our group, looked at patients, looked at ECGs in over 1 million patients in the Mount Sinai system, and separated those patients who had this so-called intra-atrial block, meaning P-wave duration, and looked at outcomes. And here's what you see. In those patients that had a history of AFib, it made no difference in terms of predicting subsequent events. And that's not a terrible surprise, because we already know these patients have AFib, and they're already going to be receiving oral anticoagulant. What was interesting is patients who didn't have an AF history and no AFib in follow-up, those patients had a higher event rate. And the purpose of this is really to show that you can use electrical information, which is indicative of some structural changes probably, which predicts a higher risk population. What about non-invasive detection? Well, probably the biggest, there's 2 important trials. Well, there's several, but the 2 biggest ones I would say are Stroke Stop and Guard AF. So Stroke Stop was almost a population level screening, looking at patients who were 75 or 76 years old in Stockholm. So a lot of patients. And the screening strategy included, again, over 28,000 patients, and these patients were randomized to either a control group or an invited to screening group. And if they were invited to screening, they received a 2-week intermittent ECG monitor. And if that showed atrial fibrillation, then they would initiate oral anticoagulation. The primary endpoint was a composite of stroke, systemic embolism, death by any cause, or hospitalization for bleeding. And here's what was seen. For this primary composite, there actually was a statistically significant reduction in this primary composite endpoint with a p-value at 0.045. The absolute difference obviously is not that great, but again, we're talking at a population level, so this could have a big impact. If you look at specifically ischemic stroke or systemic embolism, you see a hazard ratio of 0.92, but did not reach statistical significance. So Stroke Stop is a positive study, but not one that we could easily implement in clinical practice, at least not with this kind of an effect. There's also the Guard AF trial, which was just recently presented at the ESC meeting. And was a very impressive effort. So the idea was to, again, to look almost at a population level and do a randomized trial to see whether or not screening can improve outcomes in the elderly patients. So patients who are 70 years old or greater, who were not receiving oral anticoagulation and didn't have a history of AFib. So these are just basically elderly patients. They were randomized to a strategy of usual care or screening the arm. And the screening arm, they received a surface patch monitor that you wear for 2 weeks. And if that showed some AFib, then that would initiate oral anticoagulation. And the question was, if you use this strategy, could you actually reduce stroke outcomes? The goal, as you see, was 52,000 patients, very large trial. Unfortunately, COVID caused the sponsor to terminate the funding, so the trial was not completed. So only about 12,000 patients are enrolled, again, with the goal of 52,000. So let's see what happened. So what you see is, again, when you screen, you identify more AFib, and that's been seen in pretty much every trial. But if you look at the primary outcome of hospitalization for stroke, there was no significant difference between the group. And of course, again, there was just a quarter of the patients that were expected to be enrolled were actually enrolled in this trial. So this is my final slide. So in terms of opportunistic identification with patients who have implantable devices, we see, based on Artesia and NOAA, that oral anticoagulants reduce the risk, but you do pay a bleeding penalty. And so the key seems to be patient selection. And perhaps, at least at this current stage, we're looking at high CHAS vascular patients, meaning with a high stroke risk, to include those patients. But this probably needs more work. What about prospective screening? Well, whether it's invasive or non-invasive, we know that you can detect AFib more frequently when you look for AFib. The problem is we have not yet seen improvements in clinical outcomes. And probably what we need is modulation by risk predictors. You know, when you look, this is from one of the very famous publications where the idea is patients, if you look at patient risk on the top and duration of AFib on the bottom, the higher the risk and higher the duration, the more chance of having stroke and probably more chance that you'll benefit from oral anticoagulants. And the question is, maybe there's a third dimension here, looking at other factors, whether it's humoral factors like NT-proBNP, imaging factors like, for example, left atrial size, ECG factors, et cetera. What does seem to be clear is we need a better way to identify these patients who would benefit from oral anticoagulation. It's not simply identify AFib or atrial high rate episodes and give oral anticoagulants. Thank you.